Hello and welcome to All Coronary Physiology Cardio Webinar Series. Please subscribe to our channel to receive most recent webinars related to coronary physiology, assessment, and innovation. Thank you for watching. Thank you everyone for being with us tonight. It's 5 p.m. Eastern Time. Today we're coming with a phenomenal panel on All in Coronary Physiology monthly webinar series. We have a recurring visiting panelists as well as attending, as well as a new venue we started this time by coming to you with a live case, and you have an opportunity to interact with the operator as well as ask questions. With no further ado, because we have a full hour for you, I would like to start the program. As you register to the program, the agenda, I'm going to talk about physiology-guided robotic PCI. It's a live case by Dr. James Harvey. And then we're going to go over some major trials related to physiology and interventional cardiology from Sky EuroPCR, updated by Dr. Poonam Valagapondi. And then physiology-guided coronary lithotripsy case by Dr. Philippe Généreux. We would like to start first by doing some housekeeping. Again, use the Q&A box for any question, or the chat box for any question to the panel, as well as the operator. Please, this webinar will be recorded as well and will be hosted on the All Coronary Physiology and Opsens Medical YouTube channel. I would like to thank Opsens Medical, Charles, Chantel, and all the team who make this opportunity possible. With no further ado, I would like to present to you Dr. James Harvey. He is interventional cardiologist with WellSpan Health. He attended undergraduate and graduate school at Vanderbilt University, and then went to a medical school at University of South Florida College of Medicine. Dr. Harvey then did his residency training in internal medicine at Emory University Hospital in Atlanta, Georgia, and completed his fellowship training both cardiovascular medicine and interventional cardiology at Cleveland Clinic in Ohio, where he also served as a chief interventional fellow. He's board certified in cardiovascular medicine, interventional cardiology. Dr. Harvey has a special interest in structural and valvular heart disease, complex coronary intervention, and mechanical circulatory support. He is the director of the cath lab and structural heart program at WellSpan New York's hospital. And I had the privilege myself to come to one of his CTO courses and to scrub behind him to go with the cases. Dr. Harvey, if you would like to share your lab or your screen and unmute yourself, and we'll take it from there.
Chadi, thank you so much. As always, it's a real pleasure to work with you, and it's a pleasure to be here. I want to thank everybody from Opsens and also from our Avail team who are using their console to stream in live. I'll actually introduce I have one of the greatest lab staff that exists. I have Sam will be working you're not going to see her right now, but she's up working with the patient. We have Steve, Lauren, Victoria, and Julie as rest of the Avail team here. So we're going to start with a case here, and it's a little bit of a unique case we're excited about. Matt, if you could take over the slides, we'll just show a little bit about this patient. Perfect. Can you see? It looks like it's in presentation mode. Any chance we can take that out? Okay, perfect. So go back one. It's my privilege actually also to work with Dr. Rhiannon Davies. She actually, after finishing her training at Yale, went up and spent a year with Dr. Bill Lombardi up in Washington as being a real expert in CTO and complex coronary. So next slide. The patient we have here is a 73-year-old woman. Actually, you can see her past medical history. She had exertional dyspnea, type 2 diabetes, hypertension. She'd had persistent AFib, multiple TIAs, and actually her Chad's VAS score was 7, so she was actually sent for a watchman. But our EP doctor saw her, said, you know, you're pretty short of breath. So we went in and got a PET scan, which had severe degree of ischemia involving the basal and mid-inferior wall. Next slide. Go ahead and just hit the first button that'll play. You can see it's not subtle there. You can see that critical stenosis at the ostium on the right. You can go to the next slide. The rest of the RCA territory was fine. Next slide. And if you look here, you can see that what I actually had called, I didn't take these angiograms, but actually I thought that was fairly, especially with that long of an LAD, an indeterminate lesion that I would say angiographically looks more moderate, but with that long of an LAD, we thought would require a little further intervention or at least assessment. Next slide. And then you can go to the next slide as well. You can see here, just a little different view there. But that one area of about a tubular sequential 60% stenosis in the LAD. So go to the next slide. So we actually, the operator at the time said, this is multi-vessel disease. You could argue the LAD it would need treatment. Actually had just got cardiac surgery's involvement. And they said, this is really better suited for PCI, give her comorbidities and frailty. So next one more button there. So a quick question, what would everybody do here? I know we'll get to the case. You can obviously guess what we're going to do. So go ahead. I can tell you what our thought was. This is that we go ahead and next slide. So we thought, looking at it just out of the gate, we didn't want roto-regret, particularly the ostomy RCA. So we're obviously going to treat that with rotational atherectomy. We also thought we'd do a physiologic assessment of the LAD, given that territory there. We've done some studies looking at finishing up with robotics after doing, for example, complex coronaries and CTOs. And we found that even if you do all the aggressive wiring and connecting the dots by hand and then convert to robot, you can have a 50% reduction in radiation. So that this is something we've become our mainstay. So let's go ahead and go. We can go, Matt, if you could switch over to showing fluoro and the camera over here. Could we put up the avail screen, please?
Yes, sir. Just go into it 1 second.
Excellent. Thank you.
So the screen coming, James, let me know, tell us a little bit about your experience with robotic and what cases you pick for robotic compared to others.
Excellent, happy to. So we've been lucky. We've been able to work with the Corindus systems from first generation to this generation. The first generation was the CorePath 200, and it was very functional, but it was a little bit clunkier. And Corindus did a really excellent job coming up with this current system, which we're using the Corindus CorePath GRX system. A couple of things about it that we were learning going on out of the gate is that, one, you don't currently have the tactile feel, which most of yourself included, we like the tactile feel. But what lacks in that, actually, there's excellent precision, and more importantly, we also found that there's unbelievable radiation mitigation, actually. And so we're finding more and more. I've done Impella cases with robotics. With cases such as CTOs where I still need a lot of tactile feel, I don't typically use something like this. I would actually make the connection, balloon it up, and then from there switch over to finishing it with the robot. And I'll show you. This is a typical case we do right here. Can you see on the right side of the screen? These are our fluoroscopy images from today.
Yes.
We went in first here, went ahead and you can see that critical stenosis. It looked more calcified originally, but my plan out of the gate was do rotational atherectomy just because I've been burnt on under expansion of osteolytes before. So that's what we did. I wired it, went down with a microcatheter, traded out for a rotofloppy wire. You can see here, just did a 1.5 burr rotational atherectomy. For sake of time, I won't show. We ballooned it to get flow, and then I did a optical coherence tomography, did an OCT, which I've become more and more of a fan of. And you can see we had a nice dissection, got good expansion there. And then from there, went ahead and treated this based on OCT measurements. We used a 3.0 28 millimeter drug-eluting stent. In the ostium, I've quit trying to hit it right at the ostium. I'll actually flash or using it. I found it to be nice in this situation, so you don't have to guess about the ostium. And then we repeated an OCT, and we were really happy with our result. We had excellent areas throughout, and this is what we were left with, as you can see right here. So from there, we're happy to talk about that, but I'm also happy to get to the case. So we thought, we considered this a success. We were happy about this. And at this point, we were hoping to go ahead and do an assessment, a hemodynamic assessment. I'll go ahead and show our coronary here. You can see there on the right side of the screen, you can see that kind of tubular 60% stenosis. What we've done, we've given the robotic system the versatility of the Opsens wire, the Opta3. We can, with this system, we can actually go in, we can zero or equilibrate the system, we can detach it, use it on the robot, which is exactly what we've done. And so now we're all set up here. I'll kind of show you where we're at on fluoroscopy. You can see on the right side of the screen, we're set up. This is just a caudal situation here. So what I was going to do is go ahead and start wiring from here with the robot, switch to a cranial, wire down, and then we'll kind of go from there. Real quick, what you see is I'm in the control room. I'm actually behind the wall, behind the glass. I'm talking via headset to my team because I'm completely shielded here. And you can see that I've got I'm going to enable here. And what you can see is I've got the device. So if I want to use a balloon or stent here, guide wire here, guide catheter here. This was a really nice advancement with the going to the CorePath GRX system, and that how many times you need to kind of manipulate your guider while you're wiring. So hopefully here we can give a good demonstration of this. And if you're okay with it, we'll go ahead and get started. I thought I'd do this just to show the hands here and what the actual fluoro is going over there. Does that sound reasonable?
Perfect.
Good deal. All right, so you can see here, I'm easing in here. I've got control of the tip going. Sam, could you just give a puff there, please? Perfect. So I'm in the LAD. Would you mind going to preset number 1 and go up to the REO cranny shot?
So right now you're going with the pressure wire.
Correct. Yes.
And you are going to be normalizing, flushing, and then we'll be doing physiology assessment.
So we actually we equalized right before we got in, so I'm going to actually go ahead and go in. We may be a little damp, so I'm going to pull the guider back just a touch. Okay, perfect. And Sam, can you give me just a touch of the flush? So we already equalized. For sake of time, I equalized outside of the left main ahead of time, and then we're already equalized. We're going to go down, flush up the system, and plan to do a DPR assessment. What do you think?
Perfect.
And so if you can look at my hands here, what I'm doing is I've actually got right to left rotation at really excellent control. Give a puff there, Sam. As you can see, the only time I want to find a septal is when I'm doing a CTO, and the only time I can't find a septal is when I'm doing a CTO. And I can find it every time otherwise with the LAD. Oh, let's back up again. I'm going to rotate a little bit. Puff that, Sam. It's kind of like crossing the aortic valve, right? Your time to cross it goes up exponentially depending on the number of close friends watching.
Curious, are you able to use the roadmap with the system, Dr. Harvey?
We do sometimes. Actually, we're upgrading this room. Give a puff there, Sam. We do, truthfully, we do it in one of our other labs that doesn't have the robot. This lab is an excellent lab, but it's an end of life, and so we're upgrading it to a lab that will give us the roadmap. Give a quick puff there one more time, Sam. I'm loving all the septal say. There we go. I like that. Looks a little better. Just rotating as I go. Puff that, Sam. So we're kind of about past the area of interest that I was concerned about. Everybody think that's pretty reasonable? You want us to go any further? I'm pretty happy here.
Looks like a good spot.
Perfect. Sam, you want to go ahead and what we'll do is we'll go ahead and flush up with saline. We'll go ahead and hook up, and then once we do that, you can take the camera off me, Matt. I would say we go over to fluoro and over to the front camera just to show the Opsens pressure system there. There, can you see that? Okay.
It's perfect.
I want you to.
How does it feel different between robotic and the hand tactile? I know that
So,
different, but how's the control of the wire? I want to talk about the durability and the torqueability of the wire.
Yeah, I think that's an excellent question, and you saw here, and of course, I want to show how easy it is. I'm like catching every septal there is, but I'm not sure I wouldn't have done that with my hands. The reality is, though, that it's actually quite easy. It's a little what I describe is you have to kind of feel with your eyes. And so you get used to seeing just as you see the tip start to move, it's it's like the equivalent of tactile feedback. The wire, you got to get used to it. And you and I both do this, similar movements in that we're kind of subtly moving with our hands as we go, kind of keeping it off the walls as we go. And so you get to where you kind of go left, right, left, right, left, right, left, right, left, right. It's a fairly quick learning curve, in all honesty. Since we're here, I'm going to go ahead and do this, but it's a fairly quick learning curve. You want to watch, you want to make sure, because you don't have the tactile feedback. If you're not looking, and you can put the wire into something you don't want to do. The truth is, all these things it's quite functional. So are we hooked up there, Sam? Perfect. Sounds good. You see that we rehooked back up there, and why don't we go ahead and give us a DPR? Oh man, I was hoping to fix. We can do another one if you like, or we can go back to live and recalibrate it. I'm happy to. We can talk a little bit about the robot. I think, Chadi, I think your question was outstanding, and that it really, if you ask me, so the truth is, the agreement we made with Corendus was that, the first generation, I kind of joked and I said it was a little bit like that game Pong. And then this generation is a lot more like an advanced Atari. And so right now we're working with them to make this more like PlayStation, right? But it's not unfeasible to see that right now our CAT scans are so good. You can do a CAT scan, you can do a CAT scan, you can find a severe lesion, a diagonal branch, you can plug that in the robot, and the robot could actually end up doing it for us at some point. But right now it's still something that we're doing by hand, but it's really quite natural once you get used to it. Why don't you do one more with consensus? And I'd be convinced with that. It's not like we're hovering at 0.9 or something like that. Go ahead and do DPR, Sam.
So what do you do when you have to put in multiple wires?
So what we do is, and it might be worth showing up there. I'm going to go ahead and back the wire out we're talking here. When we need to do 2 wires, and I'll be honest, I've done, we use it enough that I've done 4 robotic PCI cases in one day. And so you want to go, we can show, I think we're all convinced. Anybody concerned about the hemodynamic significance of this lesion, I'm pretty reassured here. Why don't we go back to input 1 and input 2, and now would be a good time though, if you like, we can switch input 2 over to robotic. So I'm sorry, ask the question again. Oh, multiple wires, I remember. So with multiple wires, what we'll typically do is what I was saying was, if the more complicated the case, typically, practically speaking, I will start the case, do the multiple wire portion just by hand. Have I done multiple wires with a robot? Absolutely. Wire in one, take it. Our team's very good at it. There's a kind of a break on it where you can put the wire and just break it. Put the second system into the motorized control that will actually wire down. And then, so you can kind of do one at a time and toggle between the two. The team, I'll tell you, our team is outstanding, and they've gotten very comfortable with this, but it takes a learning curve there as well. We had to teach them to do what we were used to doing, and like most things, you give them 5 tries at it, and they're better at it than you are. So it's a little bit of faith with your team. We have some specialists. Sam's really an expert in doing the robot. Sam is every bit as comfortable with her doing the exchanges as myself. What you see on the right here is probably worth just switching to this altogether. Why don't we go ahead and just put input 2 as a solo screen. So what you can see, this is this console that I see, actually. This is my view, my screen here. And you can see I've got live flow on the left here. I'm going to go ahead and start backing that wire out. And then you can see up at the top, actually, I have, this is all that actually, I've got the OCT screen, the image when I've done the pre-OCT for the right. You can see the reference image. You can see my hemodynamics at the top, the kind of mid portion. And then you can see I have a camera on the room where I can actually see Samantha. You can turn and wave to the camera there. So there's Sam, and we have a camera in the room, 2 cameras in the room. That if I were curious or concerned about something, I can actually zoom in with a remote control right here to see it. So this is what I actually see from the robot. I'm going to go ahead and just back the wire out. You can see the wire coming back. And then there is a rapid, like, for example, you can see the wire there. Sam, you want to center up the guide catheter? And so a couple features, going in, sometimes you're slower, coming back, you want to be quicker. You don't have to have the reserve inside. Kind of a turbo button you can watch. I can kind of just zoom the button. I can do this with a balloon. I can do this as a stent, the exact same thing. And I'll kind of go back to reiterate that not only is this kind of, I think, a technology of the future that we're using today, but the part that shocked us was when, you asked about the 2 wires. I'd argue there's no more complex case than doing you want to go back and you can do input 2 on one side of the screen and input 1 on the other. I would argue that there's no more complicated case in all of intervention than doing a difficult chronic total occlusion. And so in that situation, we didn't waste our time going with robot. We tried it, but the reality is there's still such a tactile field component to that we would do the case, complete it, and we actually we were involved in a trial with this several places around the U.S. that had robotics, and there were high volume CTO operators. And so we would cross, once we got the lesion, if it was reverse card or whatever else, come in, balloon it up. And once we had a track, we would plan on it out of the gate. There's a little dial, a gear that we put on the guider that allows the robot to turn it. And so we would convert half the cases we just finished the traditional way, the other half the cases that we could finish with the robot. And we found there was no significant difference in time. There was a 50% reduction in 40 to 50% reduction in radiation exposure to the operator, which we were pretty shocked about. We knew it was going to be something. We didn't know that'd be significant. So like I said, it's not uncommon that we'll do if we think it's a lot more practical to do the complicated part without the robot, we will, but then we'll very rapidly switch to the robot. And I think another fair question too is, what if I had trouble here? What if we had something that I need to do urgently? I can actually show you. We can pop right up and I can be scrubbed in there in 10 seconds, convert it to a non-robotic case.
How much did you notice radiation? I mean, maybe you're keeping track of your own radiation dose since you acquired Corundus or the robotic system compared before and after?
So unfortunately, not as much as I want, because I do a lot of TAVR cases and that sort of thing. We haven't quite figured that out yet. We've worked with someone with balloon valvuloplasty. We're doing some pioneering work on that. Actually, I did notice, I kind of joke. I say the two people that love me are American Express and Radiation Safety, because they're the only people who write me every month. And I will admit, since we switched to using the robot, I don't get the same notes. I don't get radiation notes every month. So it's been a palpable notice in drop.
But if
I tell you what's that?
Going to be still having a high dose if you're not using it itself. I mean,
What's that?
With the other cases, maybe that's going to be a way more radiation if you're not using the Corundus or the.
I completely agree with you. I completely agree with you.
Well, that's really great case. I mean, I'm happy for the patient. I mean, obviously, you got the answer that you definitely want. I'm happy for him, and this is or her. This is the based on the deferred data, 25% exclude PCI. If you help the right coronary, and it's very nice illustration of the ostial atherectomy, which is sometimes is very challenging. I'm really glad you had a great result. And then one more point, how you illustrated the ostial flash. I think it's in the new balloon. We used it a few times, but it has some kind of required preparation, which is very unique. But definitely it make it your stent, if it is any spots bulging out from the ostium into the aorta, it will completely flushed out to help you for future engagement in the future.
Absolutely. And I think as we exit here, Matt, if you wouldn't mind just showing the Zoom camera, and Samantha, we might, I don't know if the robot's in a position to show just the top of it, just as we kind of round out our minutes here. If anybody's interested, you can see Sam's hands there kind of on the controls of it. It's a little difficult from this angle, but if you can look, and I don't know if you can zoom on the boom camera, Matt, but you could show so what she's doing, pause right there real quick, Sam. What you can see is this is looking down from the robot down towards the femoral axis. You can see that there's the guider and the femoral axis. You can raise up a little there. And from there, there's a little tube, and Sam, I wouldn't re-engage it just for sake of safety, but that tube there's a tube that goes down over the guider to the sheath. And then you can see where her right hand is. Sam, you want to just kind of ease the wire out to show them how the wire goes into it? Yep, you see she's opening up. There are two things there, and you can see the wire. That's the wire right there, and there's a series of gears that turn it and spin it, and also there's a gear on the back of the sheath that allows us to spin, the guider that allows us to spin that and rotate that as well. Perfect. And I'll tell you, one of the nicest utilities of this is the fact that you don't experience drift using the Opsens system, and that it's wonderful in that you can zero your wire, or equalize your wire, detach it, go in there, and have extreme confidence in the fidelity of your measurements. So,
James says we're closing with you. There is a poll Charles put on the panel here. How do you see the use of robotic PCI in 5 years? It was almost 33% equal from. I'm expecting most
clear as mud. No, I think it's fair, because the reality is I kind of joke about this technology, and I look at it like the first time I got an iPhone. I'm only limited in my imagination, and this isn't just used in coronaries, but I think that's very fair. And let's face it, there's also competing factors here: cost, time, people. There's going to be people who don't. We were a very efficient lab. We were highly skeptical of the time it would take. And the reality is, once you have to get the learning curve, but once you do that, once your team is trained, it's very facile. So.
Yeah, absolutely. Thank you so much, James. Really wonderful illustration of PCI as well as physiology and showing the utility of this wire in intermediate to high lesions and how it was easy to wire, speaking to the torqueability of the wire, but also speaks into the skill set of the operator and the robot as well. Thank you so much, James. Stay with us, please,
Absolutely.
as we are
Will do.
the program. Uh, Next speaker is Dr. Poonam. If you don't mind sharing your slide, Poonam. All right,
Give me 1 second, Sharon.
no problem. Take your time. As Dr. Poonam Velakapudi, she is a friend and a phenomenal interventionist. She is a structural interventional cardiologist and assistant professor of medicine at an associate program director at cardiovascular medicine fellowship at the University of Nebraska. Her clinical interests include high-risk PCI, mechanical circulatory support and shock, radial access, large bore access, percutaneous TAVR, and TMVR mitral clip. She also has a strong interest in education, advocacy, and increasing promoting and participation of women in clinical trials. She is a fellow of the American College of Cardiology and the Society of Cardiovascular Angiography and Intervention. And she's currently served as a chair of the ACC Early Career Section and past chair of the ACC Fellow and Training Section and co-chair of the SKY Education Committee. She is a strong proponent of using social media for fostering education in cardiology. Uh, with this introduction, very humbling, but Poonam, I know her for a while. She is a leader, she is an advocate, and she is a phenomenal operator. And really, I'm privileged to have you today with us, Poonam, for your time and for to present to us update from SKY EuroPCR latest in physiology.
Thanks so much, Chadi. Chadi has been a great friend. We trained the same year for interventional cardiology, and we've been really friends for quite a few years now. And so thank you so much for having me. And I've so much to say about you, but we'll reserve it for another time. So I'm going to present the physiology trials, not all of them because of the time limitation, but some important ones from ACC and EuroPCR 21. So I'll start with the Flower MI trial that was so popular at ACC 21. This is the multivessel, so give me 1 second, my slides. Multivessel PCI guided by FFR or angiography for MI, the Flower MI trial. So this trial aimed to evaluate complete revascularization, FFR versus angiography. And this is among STEMI patients who had primary PCI of their culprit lesion and had another one or more non-culprit multivessel CAD of more than 50%. So they were randomized 1:1 fashion. So it's a randomized controlled trial. Patients with STEMI and multivessel non-culprit CAD were included, and exclusion criteria were single vessel CAD, hemodynamic instability, previous CABG, CTOs, and coronary artery calcification. So 1183 patients met the eligibility criteria, and then the exclusion criteria were applied, and 1171 were randomized with 581 to angio group and 590 to the FFR guided group. So here are the baseline characters. The table is pretty big, but there were not significant differences in the baseline characters. In terms of the procedure-related characters, the lesions with PCI, as expected, were 55% in the FFR-guided group and 90% in the angio-guided group. Similarly, patients with one or more PCI, so more than one PCI, were also higher in the FFR-guided group. So these were the primary results. The primary outcome was death MI or urgent revascularization at 12 months that occurred in 5.5% of the FFR guided group and 4.2% of the angio guided PCI group. So no difference between the two, and the secondary outcomes were not different either. And so the conclusions from the trial are that in patients who had a primary PCI for STEMI and have non-culprit multivessel CAD, FFR-guided strategy did not reduce the composite outcome compared with an angiography-guided strategy. So current guidelines recommend complete revascularization to be considered during index hospitalization for STEMI patients with multivessel CAD, but based on this trial, FFR-guided versus angiography-guided strategies are both accessible for management of residual CAD. One thing I wanted to point out was that the number of patients who got an index PCI was only 4%, And the 96% got the non-culprit PCI at a stage procedure during the same hospitalization. So the authors concluded that given the wide confidence intervals for this estimate of effect, they said the findings do not allow for a conclusive interpretation. And about 8,000 patients would have been needed to actually reach the power. So again, to be taken with a pinch of salt. So moving on to EuroPCR, this is a trial that looked at the clinical impact of FFR-guided PCI compared to angiography-guided PCI from the France PCI registry. So this trial compared FFR-guided PCI with angio-guided PCI in chronic coronary syndrome patients. So these are stable patients with lesions less than 90% and who underwent PCI between 2014 and 2019 from this very robust France PCI registry. So it's a prospective multi-center registry trial. The primary endpoint was MACE, composite of death, MI, stent thrombosis, revascularization, stroke, and bleeding. And they included all patients with chronic coronary syndrome who had a PCI from this registry. And exclusion criteria were ACS, patients who had more than 90% stenosis, or PCI in grafts, patients that they used mechanical assistance, or patients in whom they did not have clinical follow-up. So 52,000 patients were included in this. And after exclusion criteria were applied, there were 14,000 patients and 13,000 in the angio-guided. And look at the number, only 9% were in the FFR-guided PCI. So though it is a standard of care, we're still not seeing much of FFR use from this registry. So these are the baseline characteristics. There were a couple of differences in age, sex, diabetes, smoking, family history, stroke, previous PCI, and ejection fraction. Now vascular access and left main stenosis. And the contrast medium was more in the FFR-guided group, and there was more left main stenosis in the angio-guided group, which is surprising, though the numbers were not super different. So these are the results. There was no significant, there was a difference in the MACE and other outcomes. FFR group had lower occurrence of MACE as well as death. Now, after adjusting for confounding factors that we saw, there was no difference in all these bottom outcomes, but the cardiovascular death, non-cardiovascular death, and unknown cause of death all were lower in the FFR-guided group. So after the confounding factors were adjusted, the rate of death at 1 year was 64% lower in the FFR-guided PCI group. So FFR definitely works here. So the conclusion was that FFR-guided PCI is safe and probably safer than angio, obviously, at 1 year in stable patients who had less than 90% stenosis. And the rate of death observed was 64% lower in the FFR-guided PCI group. There's some important caveats. The number of data, such as the FFR value and the type of coronary lesion, etc., were not available, and only the global syntax score was available. They also reported only 1 year of clinical outcome due to registry design, and therefore those patients with more than, who did not have the 1 year outcomes were not included in the trial. So the next trial is moving on to IFR, IFR for the assessment of non-culprit lesions in patients with ACS. So this is a multi-center observational registry, and the trial analyzed the use of IFR in patients with ACS, NSTEMI and STEMI, who had successful revascularization of their culprit vessel. And the primary outcome was, again, composite of cardiac death, MI, stent thrombosis, and new revascularization. And so the patients who were included in this trial were those who had one or more non-culprit lesions with 40 to 80% stenosis, and they were physiologically evaluated with an IFR, either during the index procedure or a second procedure within 30 days post their ACS. And so the sick ones, the cardiogenic shock and severe RVLV dysfunction, and without proper revascularization of the culprit vessels, those patients were excluded. So this trial had 363 patients. Those patients who had an IFR less than 0.89 were the PCI group, more than 0.89 was the deferred group. The group that had less than 0.89 but had diffuse disease were deferred as well. So you can see the end STEMI were 65% and STEMI were 35%. Heart failure was greater in the PCI group, otherwise there were no other significant differences. And you can see that the radial axis syntax score and culprit vessel were all no different. The PCI group had more LADs and the deferred group had more RCA. And all these, the stenosis percent, the lesion length, bifurcation lesions, baseline IFR, and use of syncretion were all higher in the PCI group. So these were the results. You can see between this NSTEMI and STEMI groups, the primary endpoint occurred in 9% of the patients. And on the right, based on the presentation, you see that there were no differences in any of the primary, secondary endpoints and the MACE events. And again, based on IFR, there was no significant difference in any of the events. Thus, IFR-guided PCI in non-culprit vessels seems to be safe with an acceptable percentage of MACE rate at midterm follow-up. So this adds to our available the information that we needed. We usually don't have much information in non-culprit vessel physiology, and so this helps. And it's safe to defer non-culprit lesions without physiological significance guided by IFR in this trial. So the last trial I'm going to talk about is this coronary angiography-based VFFR for fast physiologic assessment of stenosis severity. This is the FAST-2 study. The aim of this study was to validate the 3D QCA-based VFFR software, which you can is done with the CAS system in a multi-center setting as compared to invasively measured pressure-based FFR. So this is a prospective observational multi-center study. The primary endpoint was again a composite of cardiac death, MI, stent thrombosis, and new revascularization. And these were the inclusion criteria. Both stable as well as unstable patients were included. STEMI were not. Pre-PCI FFR was indicated in any intermediate lesion, which was 30. Here it was defined as 30 to 70% diameter stenosis visually. And again, the sick patients, STEMI, cardiogenic shock, severe hemodynamic instability, and all these were excluded. So 391 patients from 6 sites were included, and then they had 54 were not analyzable. So finally, they had 337 patients who were eligible for the core lab VFFR, and 3 patients had no FFR values available. And finally, it was 334 patients for final analysis. Out of these, 85% had optimal undamped waveforms, and 15% the pressure waveform was not available. So for those who haven't used this, the VFFR is done with 2 contrast-filled angiograms that are, from 2 orthogonal views that are 30 degrees or more apart. So it's calculated by this CAS workstation, and you get a value. You just have to input a few things and you get the value. And this is a baseline characteristic. You can see 75% males. And then there was 85 or close to 83% stable angina, and 17% were unstable or NSTEMI lesions, and most of them were LAD lesions. So this is these are the results, and if you see the mean FFR and mean VFFR from the core lab, 0.83 plus minus 0.08, 0.83 plus minus 0.8, and the mean percentage correction from the site to the mean VFFR of the core lab was only about 9%. So the VFFR site was 0.82, core lab. So you can see that the numbers FFR less than 0.8 was seen in 36%. From the core lab, it was 34, and from the site, it was 32. So the difference was not a lot. Now, the primary results based on core lab analysis are shown here. The diagnostic performance of VFFR as compared with FFR with a reference of 0.08. It shows a high positive predictive value, negative predictive value, and accuracy all are 90%. The mean bias was 0.0029 with a standard deviation of 0.064. And the AUC for VFFR was 0.93. You can compare it with the 3D QCA, which is 0.71. And similarly, here's the site analysis. It's consistent performance of VFFR by core lab or the sites. The positive predictive value was 79, negative was 85, and accuracy was 83%, and you can see the mean bias, and AUC was 0.91. So the FAST2 study shows high diagnostic performance of VFFR with the FFR of less than 0.8 as reference, both when they were calculated inside and by a blinded core labs. And there's a strong correlation between the site VFFR and the VFFR at the core lab. And thus this could be a promising new technology that allows for a faster and easier physiologic lesion assessment with minimal need for contour correction. So based on all these 4 trials, I just wanted to give you 4 summary points. Number 1, the flower MRI in STEMI patients who have multi-vessel disease, complete revascularization is suggested, and either you do it FFR guided or angio guided. Seems like there was no difference in the outcomes. The second point is that in stable angina patients, FFR-guided PCI certainly improved outcomes compared with angio-guided PCI, so use physiology. The third point is that it is safe to defer your PCI based on IFR less than 0.89 in non-culprit vessels in ACS patients, STEMI excluded, with successful revascularization of culprit vessels. So deferring based on physiology seems to be safe. And VFFR is a promising new technology that allows faster and easier physiological lesion assessment with minimal need for manual contour correction. So thank you very much.
Thank you, Bonam. Really a phenomenal presentation and summary for all the physiology trials came in the last 2 months between SCAR and EuroPCR. I was a little bit surprised from the flower trial findings, especially that we are already advocating for more physiology, and this kind of study came kind of confusing, or not confusing, kind of different what we do every day. But I don't think based on this finding and only 1 trial, going to make it change the practice that we do now. And it's nicely illustrated with the subsequent trials that IFR or physiology, it's crucial for management of these patients, whether with stable or unstable coronary artery disease or ACS. Something to keep in mind, I think maybe during a STEMI, something we can bring the patient and stage it later on, maybe due to change physiology, ejection fraction was not controlled for, the level of shock or LVEDP was not controlled for. So all these factors kind of contribute to the variability of the study.
One point I just wanted to make in the STEMI group was that after 6 months, there was divergence of the 2 curves. And the authors pointed out that that probably was related to the lesions that were not revascularized. That's possible, but again, we know that the more significant lesions are not where we actually see, the plaque ruptures and stuff. So we'll have to see.
Absolutely. I mean, I don't know, Philippe, I know you are busy. You just came seeing a patient. I don't want to, I wanted to start, but what do you think, would these trials or any of these would change your practice and the way you do physiology in STEMI patients?
That's a very field. And what you can hear me yet?
Yeah, we can.
Yeah, so I think it's very controversial. I think most of the time is a common sense prevail. And if you do a STEMI at 2 a.m. in the morning and you take the slam dunk RCA and you have like a complex vascular later, you're not going to start to go vascularization at docs. Common sense kind of. What I like and what I think the common sense tells us to do is to maybe stage a procedure, and then when you bring back the patient, now I always do physiology to assess what's need to be done. There's still a hot debate with ACS and to do some sort of plaque seeding for potentially multiple plaque rupture. It's not solved. I think we will need a lot of more trial in this field. And I think the ischemia trial go on the other way, where if you do very aggressive medical therapy and you're vascularized, but it's maybe functional, I think you will rarely do a mistake. And I think this is what we learn is it's safe to defer in stable patient based on FFR or the physiological assessment or DPR. In ACS patient, they're not all equal. You have a STEMI and shock, which is different than a STEMI with inferior wall and of a small territory, and it's different than a STEMI with multiple vessel. But they are all different entity, and we never have one size fit all and one answer for all. At the end of the day, to have more information on what could be potentially significant at the time, I think is very useful. One thing I know is when it's significant, and by physiology, I will revascularize. What is not known is when it's not significant. Okay, what you tell me is like you can have a rupture plaque. It's hard to predict the future.
That's very well taken point, Philippe. And I would like you to pull up your slides, please. Or do you want Chantal to pull it?
Yeah, please, Chantal. Do you think you can pull the slide for me?
Yes, I.
Sure. Perfect. Philippe, I would like to introduce Dr. Philippe Genero. He is an interventional cardiologist and internationally recognized leader in structural heart disease, multiple publications in that sphere, as well as a trialist in that space and complex coronary intervention. He has been a practicing interventional cardiologist for more than 12 years. Dr. Genero is the director of a structural heart program at Morristown Medical Center. Dr. Genero also has served as the primary or co-investigator for more than 20 clinical trials and published more than 300 articles in peer-reviewed journals. Majority of them, I think your impact factor above average is maybe above 11 or 12, which is phenomenal. A celebrated researcher since the beginning of his career, he was awarded the prestigious Thomas Linimier Spirit of Interventional Cardiology Young Investigator Award at 2012 at TCT, which is a well-recognized award for all high impactful research for physician and younger than 40-year-old. Dr. Genero received his medical degree from the University de Montreal, Quebec, and Canada, and performed his interventional cardiology structural fellowship training at Columbia University in New York City. All right, Philippe, just prompt Chantal, and we'll move over your slides.
Thank you so much for the introduction. So I will try to be brief and just want to share with you some sort of paradigm shifting therapy I've been using with shockwave lithotripsy and in partnership with Opsens FFR assessment. Here are my disclosure. So I want to present you, next slide, two cases. The first case is a 69 years old male, hypertension, dyslipidemia, is a lung cancer survivor with lung surgery. And he came with some classical angina, now 3 out of 4. Next slide. You can see this angiogram. The loop will play by themselves, Chantal, so you can let them play. So we perform first angiogram, and you can see here intermediate lesion of RCA. Difficult to see if there's a tight lesion in the proximal part, which I believe was initially. And then you have this OM1, which can be seen as severe, but was literally intermediate. Next slide. And you can see this severely calcified bifurcation, LEDD1. Diagonal is not super big, but this is a diagonal you maybe don't want to lose. Now you see on the steel frame on the right, you see the zero calcium in the bottom of the LAD. So certainly something we want to use with plaque modification, but this lesion was severe. But what I did is I did an assessment with Opsens DPR. Next slide, to make sure that which lesion to revascularize. I always do a little CNA of the chest, and you can see here the patient was turned down for surgery due to the calcified aorta. So it was presented to the surgeon as a 3-vessel disease, and when you look at the aorta on the CNA, decided to turn the patient down with reason. Next slide. What I decided to do when the patient was referred to me for 3-vessel PCI, I said, first, let's reassess the coronary. I will do a physiological assessment of RC and OM1. And potentially PCI LADD1 physiology guided with shock wave. Next slide. So funny enough, the Opsens up to wire 3 was negative for the DPR was 0.98 on the RCA, which was a good thing for the patient. Next slide. And also the OM1 was negative with 0.99 unequivocal. And this is very important because you transform a patient with 3-vessel disease now with a single-vessel disease, LADD1. That could have changed actually the how many other things are happening prior to putting in transfer orders, but I'm not saying it couldn't be a layer that we could add.
One second, Philippe. James, can you mute yourself, please? I think we're hearing the background from the
Sorry, I thought I was muted. We'll make sure everything else is muted here.
No problem.
Oh, now you took control. Good.
That's my fault.
No problem, Jude. I thought you have a question. So maybe Chantal, you can bring back the intervention. So this patient showed 3 vessel disease initially. You can go to the slide of the PCI. Next slide. Next slide. This one is good. Yeah, you can go there. Yep. Next slide. Yeah, perfect. You can put the, yeah, and then in full mode and click on the picture. So I did here, you can click on the video maybe. So you see actually the DPR was positive for the LAD. So what I did, I wire both lesion, and the wire in the LAD actually is a Opsens wire. I just kept the wire in the LAD, pre-dilate with the 2 compliant balloon. Next slide. Then took a trio non-compliant, can see the waist at the level of the diagonal. So what I decided to do is on the Opsens wire, still bring a shockwave balloon, trio. Next slide. And you can see the shockwave cross pretty easily on the Opsens wire. Obviously, I have a body wire in the diagonal, which is always helpful. Next slide. Dilate like 3 times with the shockwave pulse, 3 times, and you can see a better expansion. Next slide. And this is the result after the shockwave, a very better expansion. We pinch a little bit of diagonal. We're going to treat it later. Next slide. We implanted a stent as a usual fashion, but do DES, mid LAD, prox LAD, did a little kit at the end, still on the Opsens wire, and actually post-dilated with a 26 atmosphere balloon in front of the diagonal. Next slide. And that's the final result with a very good result.
Oh.
In the diagonal. And next slide. I did also the Opsens, the DPR post. You can see it in the LAD, the DPR was 0.96. And what I did actually, I did a pull back with the Opsens wire and put in the diagonal, and the diagonal was 0.94. So very good result pre and post, and physiology guided with Opsens and shockwave.
I was, Philippe, a question about how was your wiring through the struts going back to that diag with the Opsens wire?
It was very easy, actually. One thing that, you know, I use a lot of Opsens wire, especially in bifurcation, because I like to interrogate the side branch and swap in the main branch, and it's pretty easy. It's very like a workhorse wire. Sometimes we gel this wire, it's still working well. So it was very easy.
What an outstanding result. This was an outstanding result.
Yeah, and then you know what I like, what I like about shockwave, and it's you know, you don't lose your wire in the side branch, and what I like about Opsens is you can keep your wire in the side branch and still working. So I think these 2 technologies are very complementary, and I start to use a lot of shockwave, and I start to use a lot of shockwave guided physiology with Opsens because of the ease of use of the wire. So I think they're very good and very complementary. Maybe next slide. I think I have a quick case also, very illustrative also, very similar to your case actually, James. Osteal RCA, post-cabbage, sometimes the SVG fail at follow-up, and came with a non-STEMI. So what I decided to do, the next slide, is to, I use an Opsens wire. I just wanted to make sure the osteum was severe. Next slide. And the goal, for the osteum, the rotational or orbital atherectomy are challenging. So that's the reason why I think it's a good indication for shockwave. So what I did next slide is I put an Opsens wire down. I make sure that it was severe. Next slide, which was no surprise, was 0.7 DPR. And then I just shockwave at 3.5 the osteum. Next slide. Then I put a big DES 3515 still on the Opsens wire and didn't swap anything. Next slide. Flare the osteum with an NC 4024. Next slide. And this is the final result. Very good result with a DPR 0.98.
Philippe, as you are doing shockwave on Opsens, I mean, you know, you are doing a lithotripsy outward going to the vessel, but that wouldn't affect the integrity of the wire, and especially reading?
Yeah, no, actually, not to my knowledge, and it didn't affect. I mean, this wire is, as you know, is optical sensor. it's not piezoelectric, so there's no impact on the reading actually. Next slide. So I think in summary, these two cases really highlight some new findings that I think are useful for the viewer. Is Opsens physiology guided lithotripsy. So I find that shockwave is a valuable tool in the management of severely calcified lesions because it's simple to use. I think intravascular lithotripsy with shockwave over a physiology wire is also useful and lead to efficient flow of work. And I think functional assessment before and after shockwave could be simply achieved with the Opsens wire, and it's helpful to guide PCR optimization. And I will finish on this because I think sometimes we try to, there's a lot of conception that shockwave should be done with imaging, with OCT, with IVUS, it's fine, but I think in some cases it's not necessary, and to use in a workhorse wire such as Opsens with the enhancement of physiology could also be very useful. And save a lot of time and money and lead to optimization of PCI. So I'm going to finish on that. So thank you so much for the opportunity.
Thank you so much, Philippe. We have one more poll coming up. So it's interesting to see. I mean, today's webinar was really a kind of covers it all. We started with a lesion that is managed conservatively or medically because it wasn't important using a robotic technology. Then we spoke about the new literature saying IFR or physiology important in stable ischemic disease. Maybe it's not in STEMI. However, this is not the end. This is just one trial out of many findings that suggesting more physiology. And now we're closing with lithotripsy, calcification, and bifurcation lesions. So this is kind of speak to the durability of the wire as well as the function of the wire can give you a reliable readings, multiple inflations, lithotripsy, bifurcation, recrossing. I think that speaks a lot to the property of the wire. Now, going back to James, are you still with us?
Absolutely. And Chadi, if you don't mind, I'd like to make one comment. We've known for 20 years that a physiologic assessment after PCI or angioplasty predicts outcomes, but the reality is none of us do it because with every iteration of promised piezoelectric system, you just have to no matter what anybody says, they're going to get drift and you have to re-equalize, and in the end you're going to re-instrument. And I think what Philippe showed just speaks volumes, and that we can do it reproducibly and rapidly now, and that just gives us such a confidence that we really didn't practically have before.
And that's what becoming an emphasis now, as you mentioned, James. It's post PCI IFR or physiology. A DFR is really crucial. This is how you make safely walk out from the case, feeling safe that the stent that you deployed and treated this patient, especially in calcified lesion, that what Philippe showed us, is optimal. And I think this is, he's getting the cutoff and the defined GPS or a PCI was 0.94, and we're getting 0.96, which is beyond ultimate. And I think that's will make the patient, you are confident this patient angina is gone, and you are confident that you are obviously give them the best result.
One thing I will add is the more I do these cases of physiology guided lithotripsy, first of all, I'm not sure we need to put a stent in a lot of these cases, but this is another discussion. But also you can still do imaging if you want after the fact. It's not exclusive, obviously, but to have, I can imagine some study having both actually. If you have an optimal result by physiology plus an optimal result with imaging, I think that could be very powerful, and we can talk eventually about that.
And I wonder if they're complementary, or if that we've had such a focus. I mean, we've known the limitations of angiography, at least in certain subsects, and so more and more we're seeing between IVUS and OCT optimization of outcomes. But I wonder if it's additive or just the objective reassurance of physiology is going to negate that, which I think would be fascinating to find out. So it's, at least looking at your cases, seeing the hemodynamically invasive assessment afterwards is incredibly reassuring to me.
I agree.
I think it's if you ask me, so there's a question coming up like which one do you do, post PCI, physiology, or imaging? I will leave to your answers, maybe starting with Poonam. But my proposal is they are both complementary, both are important. If your physiology is not adequate, you have to do more post-dilation. If it's still post-dilation didn't help, you have to image to see if there's a dissection or this is not covered stent, not covered lesion. Yeah. Uh, Poonam, about physiology and imaging post-PCI, which one you do?
I think you covered everything nicely. It's wonderful that you can work on the physiology wire, and I'm really using that now more after attending a lot of these conferences. I was actually depending a lot on imaging, but now I use more physiology. So I do a pre, do my PCI, and then I measure post. And it's really good to see the difference. I'm really optimizing now based on those results. And I can also, the serial lesions and things like that, also physiology is really helpful. So I think they're both complementary, and it's good to use both where necessary.
James?
Yeah, I think, James, go ahead, James, sorry.
No, I think I would agree with that. I think obviously we've got more modern evidence looking at imaging, but I'm intrigued. The answer is we don't know, but we had it before we had advanced, before we had IVUS that was good enough to be reliable. Before we had OCT, we had pressure measurements of first FFR and then even some other things. So there's evidence for both. Probably the more contemporary evidence is for imaging, and admittedly, I've been doing that because I trust the fidelity of it. But now that it's similar to what Philippe had shown, now that we have something that I've tested it every single time to say, did we really lose our equilibration? And we didn't. And so, I've done it for a long time. So I think, meaning after a long time. So I think it's interesting, and we don't know. And so I'm eager to see.
Yeah, so we'll try to be very brief. So I think we need to customize. If you have an intermediate lesion, it's 60% type A lesion, and you do an Opsens DPR and it's positive, you put a stent, you have stellar result by angio. Of course, if you believe you have to use an IVUS in 100% of your cases, cost effectively is not going to work for your hospital. So I think, for this intermediate lesion where we do DPR and we do physiology, I think it's reassuring to have an objective reassurance that is working, and I'm not sure you need imaging for all of these cases. On the other end, if you have multiple vessel complex PCI calcified lesion, I think it makes more sense to use on top of the DPR, the Opsens wire, to use imaging. But I would say that at the end of the day, you always need a wire down. So if you use physiology, just use it.
Awesome. Yeah, I think we covered today a lot of physiology. I think this is a webinar can be, as I mentioned, going to be recorded, but this is kind of cover the bread and butter physiology as well as complicated cases and PCI and how much we can rely on your pressure wire to do a lot of work in the lab in a very cost-effective and also safe manners. I would like, we're 4 minutes over. I would like to thank Dr. James Harvey, Dr. Philippe Genero, and Poonam Velikapundi for your time and for preparation for this, and especially coming to you live for the first time on a webinar. Really appreciate your time and dedication, and please, and thanks for the audience for sure, and for your being here, for the questions, and for Opsens for sponsoring this event. And please refer to the YouTube channel, to All in Coronary Physiology and Opsens Medical YouTube channel to refer to for recording of the program. Thank you again, everyone. Appreciate your time and have a good evening.